Hello class, my name is Sean. I will be your presenter for peptic ulcer disease. Overview, global decline in the prevalence of peptic ulcer disease, the prevalence of PUD in the US, chief complaint in primary care facilities. Duodenal ulcers are the more common than gastric ulcers. We're also going to explore the etiology, pathophysiology, diagnosis, treatment, and complications. Despite a global decline in the prevalence of peptic ulcer disease, it remains a significant health problem that severely impacts health-related quality of life. In the US, the prevalence of PUD is 1%, causing up to 54,000 admissions annually due to bleeding. About 10% of patients presenting with abdominal pain as their chief complaint in primary care facilities are diagnosed with peptic ulcers. Duodenal ulcers are more common than gastric ulcers by up to 4 times, with the disease being more common in men than in women. As we explore the anatomy, we're going to look at the development and presentation of PUD, main structure of the stomach, cellular function, parietal versus the chief cells, gastric mucosal barrier, and the duodenum and a protective barrier. The anatomy of the development and presentation of PUD primarily involves the stomach and the duodenum. The main structure of the stomach is the stomach lining, particularly cells vital for the digestive process and the gastric mucosal barrier. Parietal cells secrete hydrochloric acid to sterilize the stomach environment, and the chief cells secrete pepsinogen for protein digestion. Mucus cells produce mucus-rich bicarbonate that sustains the gastric mucosal barrier, which prevents the underlying layers from the harsh acidic environment. In the duodenum, the lining also consists of Brunner's glands that produce bicarbonate for acid neutralization, which maintain this protective barrier. If we look at the etiology, agents that destroy the mucosal barrier, bacteria, specifically the Helicobacter pylori, medications like NSAIDs, and the role in PUD, other risk factors, and initiating the development of the ulcers. PUD begins with agents that destroy the mucosal barrier, eliminating the protection for the stomach lining and the underlying tissues. This main culprit is really the bacteria Helicobacter pylori, or H. pylori, is responsible for 90% and 70 to 90% of duodenal and gastric ulcers, respectively. Medications such as the non-steroidal anti-inflammatory drugs. This class also causes the PUD and is the most common cause. Other risk factors include physiological stress, malignancy, viral infection, radiation therapy, chemotherapy, Crohn's disease, and vascular insufficiencies. These factors combined initiate the disease process, resulting in the development of ulcers. Pathophysiology, the destructive factors overwhelming our protective barriers, the destructive factors versus the protective factors, the causative factors leading to H. pylori. The destructive factors overwhelm the protective barriers, exposing the stomach lining to the HCl and pepsin action, leading to the development of ulcer sores. So the destructive factors, gastric acid and pepsin, destroy the stomach lining due to the prolonged exposure when in excessive amounts. The protective factors, on the other hand, are bicarbonate and mucus secreting protect the lining from the action of destruction or these destructive factors. Causative factors, H. pylori, again, infectious causes, inflammation, weakening the mucus layer and reducing the protective effect, as well as hindering the secretion of bicarbonate. As discussed previously, NSAIDs also interfere with the secretion of mucus and bicarbonate. Diagnosis. PUD symptoms that aid in the diagnosis. Upper endoscopy as the gold standard. Alternative diagnostic barrier to swallow study. Other tests including H pylori. PUD symptoms that aid the diagnosis include epigastric abdominal pain, abdominal fullness, bloating, nausea, vomiting, and hematemesis and melanin. Esophageogastroendoscopy or upper endoscopy is the gold standard and most accurate test in diagnosing PUD, as it can confirm the conditions such as suspected based on the signs and symptoms. In cases where upper endoscopy is contraindicated, a barium swallow can also confirm the diagnosis. Other tests include the H. pylori testing, particularly serologic testing, urea breath test, antibody measuring, stool antigen test, rapid urine test, urine-based ELSA, and the endoscopy biopsy itself. Pharmaceutical treatments strongly recommended are proton pump inhibitors. Triple regimen treatment as the first line of treatment. And then obviously we have our treatment for NSAID related PUD, and we'll discuss our unresponsive cases. Strongly recommended are the proton pump inhibitors, showing a high efficacy due to the fact that they block the production of gastric acid to allow healing and provide relief. For H. pylori related PUD, a triple regimen that consists of the PPI and 2 antibiotics is the first line of treatment, often administered for 7 to 24 days. Common drugs used in this combination include clarithromycin, pantoprazole, metronidazole, and amoxicillin. Treatment for NSAIDs related to PUD involves stopping, obviously, the use of the drug or medication, and then incorporating our previous PPIs. For unresponsive cases, in some cases, surgery is recommended. Vagotomy and partial gastrectomy is recommended. Non-pharmacological interventions typically is lifestyle modifications, increasing efficacy of PUD treatment. Strong link between PUD and obesity. We're going to discuss the stress as a relevant risk factor and patient education. For lifestyle modifications can increase the efficacy of PUD treatment by eliminating risk factors and promoting healing of the stomach lining. The patient should discontinue habits that involve exposure to risk factors such as smoking, consuming too much alcohol, drinking too many caffeinated beverages, and excessive use of NSAIDs. There is a strong link between PUD and obesity, making weight loss and dietary adjustments for healthy eating and adequate nutrition as a necessary intervention. Where stress is a relevant factor, the psychological stress obviously causes physiological stress. There should be a patient counseling on the reduction and better coping strategies. Patient education on cases and risk factors and treatment adherence is also critical. Complications. What are complications? PUD, prompt diagnosis and management. Looking at the upper gastrointestinal anemia and mortality, gastric outlet obstruction, perforation, erosion of the entire duodenum stomach wall, other nearby organs, and complications. PUD is a serious condition that requires prompt diagnosis and management to prevent life-threatening complications. Upper gastrointestinal bleeding can lead to anemia and even mortality. Gastric outlet obstruction results from uncontrolled or poor managed ulcers, which prevents proper stomach emptying that can cause poor nutrition. Perforation, erosion of the entire duodenum or stomach wall, creating a hole that causes peritonitis. The hole that forms as a result of PUD could continue into other nearby organs as acids leak onto them. Patient and family needs. We're going to discuss pain management, patient education, psychosocial support, family, and obviously financial support. When it comes to pain management, PUD causes significant pain that can be distressing to the patient, requiring prompt and effective management. Patient education, patients need to understand the condition to increase their efficacy for self-management, including information on risk factors, which include lifestyle modifications. Psychosocial support to aid patients as they implement the treatment plan and adjust accordingly. Family members also need education to understand the condition and allow them to provide crucial support in implementing the treatment plan, especially when it comes to lifestyle modifications. Financial support. Patients and families with financial limitations may require help in accessing care and the necessary medication to ensure adherence to the treatment plan. So in summary, PUD is a serious condition with severe impact, as we're going to highlight. H. pylori is the main cause of the PUD. NSAIDs are also significant contributors. Comprehensive management, and then effective and early treatment. So to conclude this, we can say PUD is a serious condition that can severely impact a patient's health-related quality of life. H. pylori is the main cause of PUD as it impedes the ability of cells within the stomach lining to secrete this crucial bicarbonate and mucus to protect against the acidic environment. NSAIDs are also a significant contributor as they undermine the production of these same components. Comprehensive management requires pharmacological options such as PPIs and the triple regimen option of H. pylori causes, alongside with lifestyle changes and patient education. Effective and early treatment will reduce the risk of complications such as gastrointestinal bleeding and worse off, even perforation. These are the references that I utilize to make this presentation. I hope you all have learned something that would contribute to your practice when it comes to the treatment and diagnosis of PUD. Thank you.